Hello, everyone. Welcome. Welcome to our Navigator Focus series. Please let us know you're here. Type your name in the chat and where you're from. So we're going to get started in just a couple seconds here. We'll wait for a few more people to log on. And for the best experience today, we want to make sure that you're connected to computer, close unnecessary windows, use the chat for questions, and please check it out now. Make sure it's addressed to everyone because our sons have great questions. We want to make sure everybody knows the question and the answer. So please make sure if you could do that now. And closed captions will be available throughout the session. And as you know, this session will be recorded. So we'll get started in just a second. Introduce yourself, you guys. Oh, here we go. St. Joseph, Eureka. Hello, Raphael. Welcome. A few more minutes for everybody to get online here. Hello, Christine from Sierra Nevada. Nice to see you. Hey, Rebecca. I just saw you yesterday from Folsom. Nice for you to join us. All right. Brenda Gonzalez from O'Connor. Welcome. That's a new name. Nash, a Dominican. Hey, I haven't seen you in a while. Glad you're back. Oh, so many friends here. I'm so excited let's get started. So as you guys know, if you missed last session, our Navigator Focus series is called Engaging Special Populations. Part 1 was tribal health. If you missed it, it is recorded. Part 2 is today, and it's racial disparities. And a lot of you already know some of this stuff, but we wanted to make sure that California Bridge was addressing racial disparities. So we have a great lineup today. I can't wait. All of our material is available under Creative Commons. And for those, I just want to give an update on our California Bridge model. We started this vision a long time ago. In 2019, we had 50 hospitals, and I'm happy to say 2022, we have over 164 site hospitals. So woohoo, you guys, we're on our goal to taking over California. So hats off to everybody here and all the hard work you're doing. You are changing lives. Quick recap of our bridge model: low barrier treatment, connection to care, that's where you are involved as a navigator, and a culture of harm reduction. That's our motto that we live by. Some objectives today for this training is to verbalize the relationship of the navigator role. And like I said, a lot of you guys are doing this work for advocating for racial equity. Develop community partnerships, that's always a number one objective, and demonstrate some strategies to support special populations, such as the unhoused or undocumented. So those are our objectives today for CEU credit. And right now we're doing the introduction. We're going to have Charles Hawthorne with us. I'm going to introduce him in just a second. And we're going to have Bethany from our Community Resource Transitions Clinic Network. We're really excited to have this new resource. And so we'll be talking about that. And before I want to hand it over to Charles. Just if you don't know Charles, you probably do from past and previous harm reduction trainings that we had. Well, he was so wonderful, and we kind of stole him over from the National Harm Reduction. I hope they're not mad at us, Charles, but we have him now. And
no, they're a fan. They like it.
Okay, good. I'm waiting, like, are they mad at us? Because that was a good steal. So he is now our equity and harm reduction project manager. Some of you may have already worked with him for naloxone and things like that. So we're really happy to have him on our team, and he's here to talk to us about racial disparities, including cultural humility. And one thing is, this will kind of just bring out awareness. It's Black History Month. And so I just wanted to shout that out as well as we venture on our racial disparity. Charles, I am shutting down and leaving this to you.
All right, let me go ahead and share my screen. All right, can everybody see this? Let me see if I can get this to a full screen view. Oh, yes, not. This is being weird. All right. Well, let's go ahead and get started. Thank you so much, everybody, for joining us today. We're going to be talking about a few different things today. And I really appreciate the setup that Sherry gave me because as we've been talking more about what y'all have been looking for as far as being able to engage around work of diversity, equity, inclusion, one of the big things that's coming out is looking for some specific ways of being able to engage with people in order to ensure you are helping everybody access the care that they need, the services they need, especially when you talk about a location like the emergency department. The emergency department is the place where people come, often because it is the lowest barrier option that they have. And that means that often you're seeing a lot of different types of people who are all coming to the same place to access a lot of similar services. And so it's important that we are able to engage with all of those people in a way that is effective, in a way that makes them feel comfortable, that makes them be able to access the high quality care that your programs offer, and then want to come back and get it again. And one of the ways that we're able to really build that into practice is through this practice called cultural humility. So just to start out, I'd love if you people in the chat, if you could just type in, when you hear the word humility, what does that mean to you? What comes to mind when you think of humility? I give people a few seconds to kind of just think about that. And if you don't want to type, that's also fine. But I appreciate you just kind of considering it. So being humbled, acceptance, not thinking I'm better, not putting your needs first, opportunity to grow. Wow, y'all are just running the whole gambit. So everything from being humble. So there's a position or not thinking that you're better or not putting your needs first. So there's a perspective of service in there. It's around, this is not about me, this is not about my needs, but how am I supporting you? I also like that Deborah had said an opportunity to grow. So it's also not just about being static and being the same, but also thinking about here's all the ways that I can shift in order to be better. Modest, acceptance, humble. Thank you, Seda and Raphael. So being able to come to people without our preconceived judgments, our preconceived notions, telling us how we think they should act. Yeah, Camilo said having acceptance that everyone is different and being okay with it. Absolutely. We are all people who have totally different experiences that sometimes bring us to the same place, but that does not mean that's a problem. Being with people here right now with them and engaging with them and acknowledging those different experiences and perspectives. All of that is exactly what we're talking about here when it comes to humility. And how we kind of landed on this concept of humility is kind of an interesting journey. And so what they're really talking about is reimagining how we respond to cultural differences that we experience between people. So when I think about this, I actually think about my mom a lot of the time. So I come to this work kind of honest. My mom has been working in diversity, equity, and inclusion for, I think at this point, almost 30 years as a Black woman in pharmaceuticals in the medical industry. And when she first started out, the big thing that they always talked about was cultural sensitivity or cultural awareness. And when we first started talking about cultural sensitivity and cultural awareness in the first kind of wave of diversity, it was interesting. I think that there was a lot of good things that came out of it. There's a lot of learning that happened about the differences between cultures. But a lot of the times, the trouble that came up to it was, okay, we can be sensitive to differences and we can be aware of differences, but that doesn't always change the way that we think and act. It kind of helps us stay in that place that's maybe comfortable where we're noticing differences, but it's not actually helping people who are different than us feel safer in our places. So that might be things where it's like in our programs where we might acknowledge that people have different holidays than us, that we might acknowledge that people use different words than us to describe things. But we might not actually be making it safer for those people to be part of our groups. And then from there, the way that it kind of grew was towards this new perspective of cultural competency. And so cultural competency kind of put more of an emphasis on learning about culture, engaging in people's culture, being a part of it, seeing where it's about, which is also a really cool concept to kind of get into things. But there's still a kind of a trouble that comes up with that, which is, can you ever really be fully competent in a culture that is not yours? And a lot of times the answer is no. If it's not your experience, it's really hard to be able to engage with that. You know, in this world, I am a queer person, I am a Black person, I present as a man. There's a very specific set of experiences that I have. And no matter how much I talk to people, no matter how much I learn from people about their different experiences than mine, I won't ever be truly knowledgeable about what it feels like to walk as that person in the world. And as soon as I make the assumption that I do, that's when a lot of problems come up. So if you just want to kind of think about a moment, like what was a moment where somebody who was different than you assumed that they knew exactly how you were going to respond to a situation? They knew exactly what you needed. And you're like, that's not quite right. I understand the effort. I get where you're coming from, but like, you don't actually know me. You don't actually know where I come from. And and that's not how I operate. And Camilo added it in the chat. Plus, people's cultures change. Exactly. So culture is not a stagnant thing. When we think about something like even like the culture of your hospital, the culture of your hospital has likely changed so much over the past 20 years. A lot of y'all probably were part of changing the culture of your hospital. And so to say that that culture is stagnant is just not true. And that's the same thing when we talk about culture of different racial groups, different ethnic groups, the culture of people who are engaging in drug use, cultures of people who are unhoused, cultures of queer people. They shift and they change. And if you're not a part of that, it's hard to say that you're truly competent in it. And that kind of pulls us to where we're at now, which is this concept of cultural humility. And how cultural humility differs from these concepts of cultural awareness and sensitivity and cultural competency is we have that awareness that culture is ever shifting, that it's changing, that we can't ever fully be competent of it, and we are still required to respond to cultural differences in a way that helps make people who are not part of the most dominant group in our culture and in our space feel comfortable and safe. And that is often our job as the people who are providing these services. And especially when I think about everyone here's role as a navigator, as a support person in these hospitals, oftentimes y'all are the people who are doing the most interacting with those parts of people's lives. Where it's not necessarily just about the medical care, but it's about people's context. You're helping people and analyze, how do you find opportunities to shift your relationship to drugs? What are the things that you need in order to feel safe and comfortable doing that? And a lot of times that goes a lot deeper than just your blood pressure or how you're responding to a medication. And it's actually about who you are in the world. And these practices of cultural humility help give us some of the tools to be able to have those conversations and hold space for people so they can go through those things. So you might be asking, well, what does cultural humility look like? And there's a few different things that are part of this. So over on the left side of the screen, we have the goals of cultural humility. And what we are trying to do with this practice is, number one, create or generate cultural safety. We want people to feel safe and comfortable being themselves in our space. And we want them to know that if they come as they are, we are still going to be with them, we are still going to support them, and they are still going to get the care that they need. Number two, we're enabling some mutual respect and mutual empowerment. I want my patients to feel safe and comfortable coming to me, telling me when I'm not doing something helpful, speaking up when something that I'm offering them actually isn't going to be helpful, being able to set a boundary with me. If they're saying, I'm not ready for treatment yet, give me a few weeks, give me a month, and I might come around. We want them to feel comfortable saying that, because we don't want them to just run away and not feel and never talk to us again. We want them to be able to know we are building a relationship together. And sometimes that when we give them the space to do that, then as providers, we are also able to, have some real talk with them. We don't have to dance around it and wonder what people are thinking, but we're able to respect each other to have real, full conversations. And that's what developing those partnerships looks like. when we're building those connections with people, it's not just about me versus you, but me and you versus the problem, which is your health issues you're navigating, any challenges you're having in your life. It's me and you versus those things together. And ultimately, we are trying to provide people the best care. We want people to get their health conditions treated. That's why they come to the emergency department, to get their health conditions treated. And then on the right side, in this pretty flower, we have what does it look like to practice cultural humility? So first, it looks like practicing lifelong learning. Lifelong learning is a very interesting thing to engage with. I think that as the world has continued to shift, as like a younger person as part of this field, I am very conscious that the world is constantly changing. Something that I talk about a lot is like, right now, I am like a young person who is very, like hip on my terms and words that people like to use to describe their identities, to describe how they move throughout the world. And 20 years from now, people are going to be using completely different words. And it's always so funny. That's not one of the trainings that I do a lot of the times is around LGBTQI identities. And I go through all these identities and I describe them and I let people ask questions. And people get really flustered sometimes because they're just like, this is so much and this is really new and I don't know how to do it. And it's just like, that's okay because you're here and you're learning and you're trying and you're putting the effort in. And that's sometimes is enough. And you know what? 20 years from now, I'm going to be sitting in your chair saying the exact same thing. So it's okay. But it's the practice that's important. And one of the ways that practice is effective is from exercising this self-reflection and critique. So it comes from when we are engaging with people, being able to think about ourselves. So when you come home at the end of the day and you think about that really hard interaction you had with a patient, not just being like, they were an asshole, I don't care, they just wanted to make my life difficult, but instead thinking about what is something that I could have done differently in that situation. Maybe it wouldn't have made a difference. But when you go into that practice thinking about, okay, yeah, maybe I was kind of having a funky attitude with them, or maybe I could have been a little bit more patient, or maybe I could have explained this a little bit more, or given them a chance to ask questions. And maybe you couldn't maybe you couldn't have done anything different. And it was just a bad situation to be in. But being able to practice being able to practice exercising that self-reflection and critique gives you a space to be able to continue to learn from those experiences. And a big part of what that also comes in is recognizing those dynamics of power and privilege. So I know something that's always really interesting being in a service provider role, especially a role like a son, is you might not always feel like you have a lot of structural power. You're like, there's all these doctors and nurses who are in charge of all these other things that are like, that I don't really have a lot of power over. There's all these people in my hospital leadership who are in charge of me getting funding. You might even look at people like me and Sherry and Latoya and be like, y'all are the people running the California Bridge program. And so y'all have the real power and all that. But the important thing to remember is when you're having patients, especially marginalized patients, coming to access services from you, you are the person holding the power. You are the person who they are like, you're the difference between them getting the care they want and the care that they're able to get. And so understanding that you do hold power in some situations, and there's other situations that you don't. And it's complicated. It's not a straightforward thing. But being able to recognize those dynamics and see what are the opportunities for you to leverage the power you do hold to support somebody, and where are the opportunities that might not exist. And being able to think and reflect on those is really an essential part of that lifelong learning. And then lastly, sometimes it's just about being comfortable not knowing. We can learn all we want, we can read all we want, we can explore what we want. But at the end of the day, sometimes it's just not, we aren't able to figure it out. And that's okay. You can come back the next day and try again. In the group chat, Chai had asked, could you share some tips to advocate for patients? So when I think about advocating for patients, I think one of the really big things I like to consider is like learning the mechanics of your system, learn the mechanics of your hospital. What needs to happen in order for people to get the care that they need. And when you're new, it might be really overwhelming, but the longer you kind of stay in a position, you start kind of figuring out like, okay, in order for this doctor to write this script, they want these three things to be in order. And so sometimes that's about going with that patient and being like, okay, you want to get this, these are the three things that you need to say. And being able to help people kind of notice where's all the red tape, where's all the little barriers that we're going to have to circumnavigate, we're going to have to like kind of go around to get to where we want to go, and really strategizing with your patients and with your clients about how to get through that red tape, because that's really where your power sits as a son, is being able to be on the inside to see here's all those bureaucratic challenges that we're going to have to navigate, and helping give people the cheat codes like on a video game to be able to jump around all those things that are sometimes barriers. And I think that that's one of the really powerful things. And then at the same time, connecting with your patients and continuing to hold that mutual respect so that they feel comfortable going on that journey with you and they don't feel like they're just getting left behind and you're doing whatever you want. I hope that was a good tip, Chaya. So that is the biggest piece of, oops, am I not clicking? Oh, okay, I see what I'm doing. All right, there we go. So yes, that is a little bit around cultural humility. And so just really quick, when you think about it, what are some barriers that you have faced when you're working with clients who are different than you? What are some issues that come up when you're working with a client that has a different culture than you or thinks about the world differently than you? What are some of the things that make doing your job hard or make supporting them hard? Language barrier, huge, 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 huge. Not being able to communicate is a big piece of that. And Sherry's going to give a little longer piece on that near the end, just to talk about some strategies to navigate that. But being able to have a translator is really important, whether that is a translating line or a person within the hospital to do translation. If you don't speak Spanish is huge. Having different goals. Rebecca said having different goals. That's definitely a thing. Maybe for some people, they're like, if the only thing I can do is be sober. If I'm not completely sober, it doesn't matter what I'm doing. Whereas we might be like, well, I want you to start worrying about getting tested for HIV and all these other things that are all pieces of your health that might not line up. Gaining people's trust. That's a big part as well. People might not trust you if you are not a person who they think they can identify with. Cultural barriers and age gaps for real, for sure. So when we're thinking about that age gap, it's like that's a culture piece as well. Is how your age and how people feel like they can connect with you as far as that. Yeah, and having many programs not developed with different cultures and genders in mind. And we'll talk a little bit more about that today. Thank you, Claire. Because a lot of times the programs that are created are not always created for the types of patients that we're seeing. And then Bethany had added stigma. So stigma is a huge thing. So whether it's our own stigma that we are exhibiting or stigma that patients we're working with might feel we are exhibiting. And whether or not it's real or perceived, it still has an impact on how comfortable they might how comfortable they might feel sharing about their history of drug use, sharing about their upbringing, sharing about the challenges they're navigating. And then Shaya added, what is easy to you may be difficult for them. For example, accessing email or finding a safe place to sleep. I think that that's actually one of the biggest things that I see a lot is like when we come and we're doing things like filling out masses of paperwork. Filling out paperwork is a skill. It is a practice skill that people have to learn. And when we have a country where oftentimes people's education is not always prioritized, people's skill building is not always prioritized, people might have been in jail or on the streets and they might not have been in positions where they had to do this in part of work or as part of a lot of different things. And even though we might be like, yep, you just need to fill out this paperwork and then wait for this email and return this call, those might be really big lifts for people who might be worried about, where am I sleeping tonight? What am I going to eat? What are my kids going to eat? How am I going to make sure that I'm not sick? All of those things might be more important and a bigger skill that they're worried about developing than how to fill out this form to get their Medi-Cal. Absolutely. There's lots of great stuff in here. Mental health and co-occurring disorders. So there's always this also like the medical side of things coming up around people's mental health. Um, and then Alejandro added, once people see me wearing my Converse, they start to ease up. I think that's a great little nugget in there as well about looking approachable, about you don't have to be all like, there's kind of a balance that I think as sons, you kind of have to strike of being professionals in this hospital, as well as recognizing that you were the first line of connection for a lot of the patients who are most vulnerable. And I think something like wearing Converse is like, it feels kind of silly, but it's like, yeah, I'm not being able to show people is like, I am a person you can connect with. I am a person who you can see, and I'm not just like all these other uptight people in this hospital. I'm a person you can see and connect with and be comfortable with. And you're going to find your own style and your own professional garb that's going to work with as you kind of learn and grow. But I think that that's a great example. And then Ruben said in the group chat that they're in Alameda County and they have some really great Spanish speaking resources out here. So if you're in Alameda County, feel free to reach out to Ruben. Okay, so just to keep pushing, some other barriers that might come up around practicing cultural humility includes like not feeling like you know enough, so lack of knowledge that makes it hard to recognize differences that even come up. Um, Sometimes it's self-protection and denial. Sometimes we feel unsafe and uncomfortable recognizing those differences. That's something that I actually would see a lot in some of my own providers. When I would talk about being queer and needing like certain healthcare around my sexual health, around my bodily health, a lot of providers were very uncomfortable having those conversations with me. And when they didn't want to engage with them, they would just say, well, like, that's not my job. That's not my problem. You need to go to the special clinic for this. And it's like, no, you're my doctor. That's your job. Um, and sometimes what it looks like is like, well, we're all human. We all need the same things. And it's like, we don't. We're all different humans who need different things for our human bodies. Um, Also, fear of the unknown or new is a huge thing. It can be really intimidating when you're working with somebody who's different than you've ever worked with before, or different than you're comfortable engaging with. Um, and then sometimes feeling that pressure due to time constraints. We're always moving so quickly. We're always having to see a new patient, and we're like, I don't have time to sit and engage with you. But if there's one thing that I have learned from doing this work is if you don't put the time in the first time, you're going to be putting twice as much time in the second time you're talking to them. And so that is a huge piece of it. All right. So I added those slides in so you can read more later when they send them out, but that's good enough for now. So now we're going to move into the second piece, which is you're recognizing you're having all these different types of clients coming into your door. And you want to make sure that those clients are having access to resources. And your hospital is one of them. But one of the big things you're also doing is connecting people to resources outside of your hospital as well. And so being able to find and connect and engage with those resources is going to do a huge amount of work for your clients. So first thing you need to work, so we're going to kind of go through these 5 steps of engaging community resources in your area. And the first step is figuring out what needs must be met and for which clients. So I think we're going to have a poll real quick. And so the first poll question is number 1, how does the racial diversity of the patients that come to your hospital compare to those that live in your city? So this is just kind of thinking about, what does your hospitals look like? Are your patients more diverse in your city? Is your area more diverse than your hospital, or are they about the same? And then the second question we have is, have you attended community outreach events as part of your navigator role? So have you gone to an outreach event where there's community resources as a navigator, either as a way to tell other people about your services or to learn about the services that other folks offer? And we'll give it a few seconds, and then whenever it looks good, Carolyn, you can go ahead and close it. All right. So on the first question, it looks like most people are saying about the same. But some people, a lot more people are saying that their patients are a lot more diverse. So if your patients are more diverse than your area, what that probably is telling you is that your hospital is probably like a community type hospital that's getting a lot more clients that are people of color that are in that area. As opposed to if the city or area is more diverse, maybe you're in a hospital that is kind of maybe a private hospital, maybe the area that it's in is catering more to a certain type of people. And it's just something to notice. It's something to, and usually what I think about is we want to be trying to strive for it to be about the same. We want as many people coming into our different types of people coming into our door as possible. And then number two, have you attended a community outreach event as part of your navigator role? Most people said no, a few, but some people did say yes. And that is a really good thing. I really encourage this as a way of finding new resources. So go ahead and just continue kind of like thinking on that. I encourage you to look into seeing if there's any community resource fairs or stuff like that in your area. So how we engage community resources, I'm just going to go ahead and move through this real quick so we have time for our guests. And the first part of engaging community resources is figuring out what needs have to be met. And so just thinking about what are some common patient needs? Thinking about, okay, my patients need access to food. They need to find professional clothes. They need help with job searching. They need money. They need to work and they're looking for jobs. They need help with legal issues that are coming up. They are looking for a name change clinic because they are trans and they're having trouble getting a job with their current name. And maybe they're needing help because they are exiting treatment and they need help getting connected to a new treatment resource because they were in a residential treatment program. Asking your patients these things is good to kind of gather a list. A good way to kind of do this is maybe over the next week, whenever you're talking to patients, ask them like, what are some resources that you would like? And just keep like a notepad of them. And if lots of people ask for the same thing, put a little check mark next to it. And the ones that are the highest need, really dig in and really try and find some resources that meet that need. So the next part is that actual search for resources. And there's lots of ways you can do this. Your hospital or your community might have some resource guides that you can start with. Sometimes those are pretty out of date, so you might want to go and like follow up and check on those resources. Doing some basic web searches. So if you're looking for job support, you can just literally search job support your county and see what pops up and see who's doing that. Also personal experience of either you or your patients, places that they've gone. And networking. So talking to other sons, talking to us, reaching out to other community providers and seeing what they have. If you have any other ideas about how people could find resources, please feel free to go ahead and throw them into the chat right now. And you can just kind of, and we can kind of look at those together as we're moving through. But a really key part of this is vetting your resources. I think so much people just kind of put the resources out there and they don't call to see if that place is still in business. They don't see if there's a case manager that's willing to work with this person. Sometimes that organization's work has completely changed. So it's important that you vet those resources. And that looks like having some questions. And we're going to practice this in just a second. But thinking about when your patients are walking into the new space, being able to know what is happening there. So when you talk to a community resource, asking them questions about how much do their services cost and what can patients get for free? What does the intake process look like? Do you need an ID to access services? How long do people usually wait? And like, what is your organization's stance on harm reduction? And thinking about some others, feel free to put other questions in this chat or save them in your brain for our wonderful guest in just a second. And so then last, I really encourage practicing warm handoffs. When you find community resources that you like, that you think are going to be good for your clients, don't just throw them into the void. A lot of times we do these referrals where we write down the name of a place on a piece of paper or we hand people a brochure and we're like, go see that. We know that that is not effective. There is data, there is research, there is personal experience that we have as case managers. Referrals are not usually successful. What does work is a warm handoff. That means that I am going to call a provider. I'm going to say, hey, Bethany, I have a wonderful client here for you, and they would love to talk to you about their service, about your services. And you can either put them on the phone, or you can say, do you have a time to meet with them? And you tell them, you have an appointment schedule. Like, when are you free? Schedule an appointment. You are going to be meeting this person. You're not just walking into the front desk and asking for someone. You have an appointment, you have a time to be there. And we know that those are a lot more effective at helping people feel safe and comfortable accessing those services because it feels more like a friend recommendation. Like when you just Google a place online to go, you're like, cool, I hope it's good, I hope it's all right. But when you like have a recommendation and they're like, yep, you're gonna go to this restaurant, you should order this and this if you like this type of food, you feel a lot more comfortable. It's more exciting. You're more likely to go. So really practice those warm handoffs. Those are really, really, really powerful. And as like a navigator, that's like what you're there to do is make sure people connect to those resources, not that they're just aware of them. All right. And then last, I really encourage follow-up. Sometimes, as providers, you're kind of sitting here like, I wonder what happened with this person. I wonder what happened with this resource. Don't wonder, find out, ask people, ask questions, talk to patients about their services, about were their needs met, were they treated well, would they recommend other people going? What did they wish they knew before they went? And if you have that contact of that other resource, call them, ask them how they're doing, and be able to see like how your patients are going or something that we should have informed them of better so that they're not as confused when they come in. All that type of stuff is really, really helpful just to make sure that you're continuing to send people to quality resources. All right, so now we're gonna do a bit of a practice session. So this is our real life case study with Transitions Clinic Network. So in this case study, while you're providing services to a client, they mentioned that they receive services from the Transitions Clinic Network. They're telling you a little bit about it, and you're like, this is really interesting, and you're interested in learning more about the program in hopes of adding that resource into your toolbox for other clients coming in. And you reach out to that case manager that your client saw via the phone number, who your client saw via the phone number on the business card that your client received. And so now I want you to think about what are some questions that you would want to ask that resource when you pick up the phone and call them. And now we're going to actually get on the phone with Transitions Clinic Network, on our Zoom phone. So I want to go ahead and hand it over to Bethany, who's going to introduce herself and tell you a little bit about Transitions Clinics Network.
Thanks, Charles. Glad to be here. My name is Bethany DeVacher, I work as a nurse program manager for the Transitions Clinic Network. So perhaps the first question you might be asking if you were to call me would be, what do you do? So Transitions Clinic Network, we focus on providing primary care for people who were recently released from incarceration in prison or jail. So essentially, our organization, we provide training and technical assistance to primary care clinics across the state to adopt a specific model of care for serving the reentry population. Our model grew out of listening to patients who had experienced incarceration and reentry, and a key component of our model is supporting clinics to hire community health workers that have lived experience of incarceration. So when patients are getting connected to these clinics, they are getting connected to a community health worker who's experienced this reentry journey that can serve as a mentor to them and help them just navigating, what it's like to come home and get reconnected to healthcare. So we currently have 21 clinic sites across 14 counties in California, and our program is growing. So we'll be adopting new sites this year, which is exciting. And I just want to take like a moment to, before I invite additional questions, just to talk about like why we do this work and what it means to serve the reentry population in general. We know that the population of people who are incarcerated or who are coming home have high health needs, including chronic diseases and mental health conditions and substance use disorders. And we know that the experience of coming home from incarceration can be really challenging for folks, like getting connected to jobs and finding a place to live and getting connected to healthcare. And a lot of times health can be kind of low on the list of priorities. But we know that people coming home are actually at a 12-time higher risk of death in the first 2 weeks from prison. And drug overdose is actually one of the top causes of death. So, we're really attentive to that high risk period of time when people are coming home from incarceration and the hopes that we can get people connected to care right away. Related to the stigma that Charles talked about earlier, we know that people who are coming home from incarceration, they can just face a lot of stigma related to their experiences being incarceration, including within healthcare settings. Like not every clinic is going to be the right place for them to get their needs met. And this, of course, is combined with other stigmas people may face, like such as people who use substances, people who have faced racial discrimination. We know that the incarceration population is disproportionately people of color. Minority populations are disproportionately impacted by incarceration in the US. So yeah, basically TCN, we're aiming to provide care that's low barrier and holistic for people, that's culturally sensitive to their experiences. We're integrated into the primary care system because we believe it's important that people get their care in the community and separate from the corrections system. But we're also, looking to provide care that's tailored to the needs that they have.
Awesome. Thank you so much, Bethany. That was super awesome. So we're going to just kind of do a little practice and offer and go through some of these questions that are in the chat. So one of the questions Chaya had asked is, what are the services available? Maybe specifically, do you offer any sort of MAT services? And it sounds like y'all more do the technical assistance and support, but maybe some of the clinics that you work with. Could you maybe answer for that?
Yeah, absolutely. So we, like I mentioned, we work with a whole network of clinics across the state. And those clinics are offering primary care services for people who are recently incarcerated. The services vary a bit by clinic, but most of our clinics will serve people coming home from either prison or jail, all adult clients. And we offer primary care, which would include like physical assessments, chronic disease management, and medication, as well as behavioral health. Most of our sites are offering that and have ex-waivered providers to prescribe Suboxone in-house. Our sites help with insurance enrollment, many help with transportation, food assistance, and then if patients need specialty services like dental, ophthalmology, they need to see a cardiologist. Like if those services aren't available in-house, then they can help with referral to those services. So if you're meeting a patient in your ED that has been recently incarcerated, coming home sometime in the last, say, 6 months, or even up to a year, we can, and if there's a TCN program that's near you, we can offer you like a direct contact, one of the community health workers at that site that can help you with, finding out if this patient would be eligible for services at their site and how to get them connected.
Yeah. So it sounds like maybe an ideal candidate for this type of service would be somebody who had left jail or prison like less than 6 months or less than a year ago and is looking to get connected with a primary care provider.
Correct. Yep. Mm-hmm. Yeah. And our goal is to offer as many services related to primary care in-house as we can, which is why, most of our sites, like I said, have providers that can offer Suboxone right in or other medication assisted treatment right in the clinic so that they can get those, services at the same location that they might also be getting their blood pressure medication or whatnot.
Yeah, so I really love that. And I think about kind of the symbiosis between maybe some of these sons in your emergency department, where your emergency department is for that immediate connection for when people are like anytime 24/7, it's the entry point, and transitions clinic next work would probably be that ongoing primary care for patients in order to ensure that they're actually managing their health in a longitudinal and a long-term way.
Yeah, absolutely. I'll just mention, like we have made referrals to patients to California Bridge programs. If we're talking with a patient who'd like just fresh out of prison and they're running out of their medications and need a place to get a refill today, then we have referred patients to ED Bridge sites to get that immediate need met. And like you mentioned, like it would make total sense for the reverse referral to happen or the reverse handoff to happen, where your team is recognizing this person needs an ongoing provider to get hooked up with, and that's when you could make a call to us. I will mention too, just in case everyone's not aware of this, is state prisons across California are offering MAT now, including buprenorphine for patients who have diagnosed substance use disorder. I can actually share a link to a substance use disorder dashboard that is public, and it shows how many people are getting SUD and MAT treatment from state prisons. So it's likely, you could be seeing patients coming home from incarceration who are on MAT. Patients get released from prison with 30 days of medication, but that means they only have a month to get their insurance activated and find a clinic and get a medication refill. So it's not much time, right? So that's why we see the services you offer as being really important. Jails are a little different. They're operated by the county. So whether MAT's offered and how much medications people get coming out of jail could vary a little bit more. But yeah, so I think I see those two services, the immediate service and the ongoing care, as being really complementary to each other.
All right. And then last question, what is the cost typically like for a patient that gets referred to you?
Yeah, absolutely. So our clinics can bill Medi-Cal insurance or other private insurances for services. So if a patient's eligible for insurance, they would definitely help with enrolling them in that, so they can get their doctor's visits and their medications paid for through that. If patients don't have insurance or they're not eligible for insurance, then our clinics will want to work with how they can see them. Then most sites, I think all sites should have like a sliding scale type arrangement. And if a patient, doesn't have income, then their lack of income wouldn't be a barrier to them getting services at that clinic because of that sliding scale. So we don't want, payment to be a barrier to people getting the care that they need. We do know that sometimes people have gaps in their insurance coming out of prison. Like, you can't have active Medi-Cal insurance while incarcerated. So there can be a gap when folks are coming home and needing to get established with primary care, but their insurance hasn't kicked in yet. They need to notify the county that they're home and no longer incarcerated in order for their insurance to become active. So that's something our community health workers can assist with, is navigating this whole time period of like, how do I get my care when I don't have insurance coverage?
That's good.
I know, Bethany, it's Sherry, and thank you for addressing the Medi-Cal, because there was some chat going on about Medi-Cal insurance and when it's activated and how they have to reactivate it. So thank you very much. And we have a poll. Do we want to do the poll before I take it away?
Oh, sure. Yeah, I just had a couple of questions for you all. I'm curious. The first question is just asking about primary care. So I'm curious if that's part of your process in addition to connecting people with services for substance use disorder, if you're thinking about where they could be going for primary care. And then the other question is just like how do you know if people are incarcerated, right? Is that part of your kind of workflow to ask patients if they have been in prison or if they're recently released? So these are just kind of some yes/no questions, which give me a little information about your network and also something for your team to think about too.
Right, that's great. I thank you very much, Bethany, for coming, because I know a lot of times will be referred and I'll refer it to a son or a son mentor. So definitely this is something that, definitely can be resourceful. So I'm really excited to have you partner with us. So here's the results, Bethany.
Yeah, so it looks like a majority of people are thinking about primary care connections. And so you can certainly be thinking about our network. Again, I'll acknowledge we don't serve everybody. There are some counties where we don't have a clinic right now, but our network is growing. And if you have one of our sites near you, we would love for you to reach out if you have a patient you think we could serve. Yeah, and I think the second question is interesting. It looks like a lot of people are also like asking this question of if people have experienced incarceration or coming out. And I understand that could be like a sensitive question to ask. So something I guess for maybe all of us to be thinking about is like, how do we help identify that as a need? Because like Charles said, we can't actually meet patients' need for community resources if we don't know it's a need that they do have. And I imagine some patients may offer that information, but also just wondering how we can be doing that full assessment of any needs that patients have.
Great. And just for everybody's knowledge, if you're on the Slack network, Bethany is part of the community resources. So you can reach out to her on our community resources Slack channel. So that's a helpful tool. We're trying to put all kinds of resources, and Bethany is definitely on there. I'm going to, do you
I'll
want
just mention, Sherry, looks like there's a question in the chat about like, how to contact us. So I did share with Sherry a list of all of our current program sites and where they are located in the city and the county and who the contact person for that would be.
Right.
So you could reach out directly to the community health worker at that clinic. That's also a number that you can give out to patients as well. Also, just to share, we do have a reentry healthcare hotline that anyone across the state of California can call when they're coming home from incarceration or back in the community. So I'll share the flyer for that as well. You can give that to patients, and that's a number that they can have on hand too. When they call that number, they're also speaking with community health workers that are part of our network. So they're kind of talking to a peer who's been through the reentry experience and can help them figure out like what their next steps are.
Great. Thank you, Bethany. And I will, we're going to send out a follow-up letter, and I will add those as well. Your information to that follow-up letter, and we can possibly put out that resource list on the community Slack channel as well. So we'll do it both ways. We want you to get the information. It's really important. And Charles, since you have the slide deck, can you just real quickly, I'm going to go real quickly. This is Sherry Cisneros. I'm the Navigator Program Director here at California Bridge. And we just wanted to address some of the trending topics of the unhoused. During COVID, it became fairly easier to have some resources for the unhoused. I know several pop-up hospital or hotels became COVID isolation resources. And now that that's kind of dissolving, I've heard some talk and some questions about what's going to happen now. A lot of you put in the chat today some resources, and everybody's in a different city, county. We will definitely still be using 211. If you don't know 211, that's the LA County line for the unhoused, for basically for everything. So really, we encourage you to check with your county, and it's really, really important to know your county resources. Temporary housing for COVID, like you said, it was the pandemic. What's the follow-up plan now? Do you have the shelters, the dates, the times they're open? Because now we're going to go back to pre-COVID, and that was one of the things that they're only open during the winter time. What are the hours to get there? So if you have not reached out, we really encourage you to reach out to your community shelters and make sure you have an up-to-date list with what's going on, just generally with the whole unhoused population. We do have definite resources. You can follow up with social worker at your hospital, but like Charles said, do some investigation on your own county level, your own city level. There are programs right there where you live. Unfortunately, we can't deep dive into every city and every county. There's too many in California, but we encourage you and to put those resources on our community Slack channel. You guys are doing that, and it's great when I see these wonderful resources. So please continue to help others. Next slide, please. Our next slide, we're going to go to the other topic, which is undocumented migrant workers. We just wanted to make sure that you guys are aware that this continues to be one of those problems with minimal solutions, but we wanted some key awareness. Their biggest fear is being reported and deported, right? You've heard a lot of, ICE going into camps and asking. And one of the things that we wanted to make sure is that you tell anybody undocumented that they do not need to give their status. And that's what they're taught. They are taught not to talk to people. So this is a very, very difficult, extremely difficult population to work with, because when they're taught not to talk to someone, it makes our job as substance use navigators even that more difficult. And the other thing is they do not speak the language, right? What resource do you have that they can connect to? And maybe this might be a community resource that you can definitely say, hey, I don't speak Spanish, but let me give you this number, or let me take your number so I can call them. I am not fluent in Spanish myself. I do not feel comfortable giving any information. And I work with our communities, a city community social healthcare worker, and she speaks fluent Spanish. So we're a great team. And the minute I know that they want to speak Spanish, I hook them up immediately. I do it even there in the hospital. And so that way, by the time when they go home, they already know. So it's, set up that referral system. Don't wait until somebody comes in. Know that, oh my gosh, I have a Chinese speaking or Spanish speaking. Let me get my referral. Have it in hand and your resource list. And then remember, most families are mixed status households. Okay. So what that means is the children are doing translation for the parents, right? The children are the ones that are kind of the window for them, in this system. So, sometimes that's not always the greatest resource is the children, because they don't understand what you're talking about. So again, make sure you have a really good, strong referral system. And that goes for any special population, anybody that doesn't speak the language, or anybody that's non-trusting. They're all kind of, it's building that trust. And I know a lot of you have said building trust is the number one thing. So I think answer some of our questions is, what's the number one thing you can do as a substance use navigator? Build that trust. So definitely want to make sure that you guys know that and share some tips. Next slide. I think we're done. Okay, so in general, for all three of us, if anybody has questions, this is the time. For Charles, myself, or Bethany, I want to thank our speakers today. It was great, learned so much. And this was just an awesome time to kind of talk, to discuss. But if you have questions, please put them in the chat. And we're still going to be here. Go ahead, and next slide. He took over again. Here is the CEU credit link for your evaluation, or if you need credit for attendance, please go ahead and download that. Again, we will also be sending this out in a follow-up letter. Next slide. And don't forget, we have our Sun Mentor team who is on our Slack channel. If you're part of that, we really encourage you to definitely reach out, and reach out to any of them. If it's not we have some county regions, but that's not always, if you need help, just let us somebody know. We will get back to you. Next slide is our social media, and we put all of our channels in the link. Join us. I know now we have live on Facebook, which is just amazing and wonderful, thanks to our comms team. They do an amazing job. Let me tell you, behind the scenes, they take care of everything. And we're so excited that they got us live on Facebook. That is just amazing. So we thank our communications team, Caroline and Aria. You guys are awesome. Next slide. And they want to see your pictures and selfies. And again, I am Sherry Cisneros, and I am the Navigator Program Director, but I'm also a son and also a mentor. So please feel free to reach out to all of us or any of us. We want to help, and we want you to succeed. That's Charles, Bethany, we're all here. You have our contact information. If you don't, just let us know, what you need, and we will try our best to get that to you. And the last slide I leave you with today is food for thought, right? Substance use is the only medical condition that's also a crime, right? You have diabetes, you take your medicine. It's not a crime. So I like this. Again, credit to the comms team. Just some food for thought. Thank you for joining us. We will have more training. Always check our website at cabridge.org for more training. And we're so happy to have you here. Thank you for all the hard work you do. Any questions? We're still here. We'll be here for a few more minutes. Anything else? Well, you guys are so much welcome. It's a pleasure. And again, thank you to our panel. Amazing job, amazing information. So thank you guys.
Thanks so much, y'all. And yeah, like Sherry said, I'm here at California Bridge. If you have any questions around like navigating any issues around cultural differences, different races, working with people who are different than you, along with the Sun Mentors, I'm like totally down to talk through this type of stuff with you. So please take that opportunity because we want y'all to be great and succeed and do all the awesome work you're doing at the highest level you can.
Yeah, and I think we took care of the questions. So have a great day, guys.
Thank
Bye.
you.